just has to start with this question: how can we collect reliable data? How can we use this data? Let's go to India, because I think that what has been done by Operation Asha is important when it comes to collecting data concerning tuberculosis.
Tuberculosis or TB is a curable bacterial infection that has become an epidemic. When a patient misses his or her doses of medicines and defaults, drug resistance develops or MDR-TB occurs. E-compliance is a biometric device that ensures that every dose is taken in front of a health worker. This way we can turn off the tap on MDR-TB. It was visualized by Operation Asha, who did the systems analysis. Microsoft and innovators in health did the technical work. A joint team carried out field trials.
Tuberculosis is treated with the DOTS program, DOTS being an acronym for Directly Observed Therapy, the short course. DOTS alone is not enough to curb the TB epidemic in high-burden countries. So what is the way ahead? It is technology linked with community empowerment, which is what Operation Asha has been doing.
E-compliance is a simple system comprised of 3 off-the-shelf components: a laptop, a fingerprint reader, and an SMS modem. Patient will register through the fingerprint reader when they first start their treatment. Every day that a patient is to take medicines, they will verify the visit by scanning their finger on the reader.
हम लोग जो है आते हैं क्लिनिक में और जो है सबसे पहले हम उंगली का निशान लगाते हैं, उसके बाद जो है रजिस्टर्ड हो जाता है हमारा नाम.
E-compliance maintains an attendance list that shows our counselors which patients have already taken and which still need to take their medicines that day. If a patient ever misses a dose, the system will send a text message to the counselor and also to the program manager to notify them that a follow-up visit is required within 48 hours. The counselor will then take the e-compliance terminal to the patient's house with the medicines. She will take the patient's fingerprint at his residence, educate the patient and his family on the dangers of MDR, and will observe the patient taking medicines.
सर इसके आने से हमें बहुत ज़्यादा फ़ायदा हुआ है कि हमें पता चल जाता है कि हमने कितनी दवाई खाई है, कब से दवाई खा रहे हैं, इससे कुछ मिस नहीं हो सकता हमारा.
Every evening, the system automatically sends the attendance information to an online SMS server. We will then download the data into our reporting system, giving us multi-level and up-to-date information. From the reporting system, we can keep track of each counselor's performance and quickly identify any medicine inventory shortages.
ई-कंप्लायंस में हम पेशेंट का फर्स्ट टाइम रजिस्ट्रेशन करते हैं, इससे हमें ये पता चलता है पेशेंट रेगुलर आ रहा है, उसने एक भी दवाई मिस नहीं करी है.
From the counselor's perspective, it's a win-win situation. The counselors are getting knowledge about computers and technology. It's adding greatly to their skill sets, and also it gives them great respect in the community. And these are people who come from disadvantaged backgrounds who are barely able to read and write.
Voilà, exemple concret.
So this is a concrete example directly in the field of what it means to collect data in order to improve the different populations' health. Now, Shelley, when we discuss about collecting or harvesting data, of course we need computers. This is important because you collect the digital footprint. But before computers, I suppose that you need men and women. You need people. They are certainly the most important, and in what respect?
That is absolutely right. And let me begin by saying that technology is the icing on the cake, so to speak. We have to have a very good program with a very sound foundation. Only then will technology work. Right. So we invariably hire and train local people. Wherever we work, it's always local people. They belong to the same community, they eat the same food, they pray in the same way, they live in the same way. And they are the ones who are best equipped to serve their own people. I'll give you an example. In Cambodia, every single person employed by Operation Asha is a Cambodian, except for the country director, who's an Indian because he has to do the liaison back and forth with the India team, especially with the technology team. So local people are best. Also, there is no road number, no house number. So I cannot go and find a patient who lives in a particular slum or a particular island in Cambodia. But a health worker who's going on boats from island to island. They are the ones who can do the job.
Cela veut dire que la collecte de données,
Which means that data collection couldn't be that precise, couldn't be that comprehensive if you had sent people not from the community, if you had sent nurses coming from any part of the country. So the data wouldn't have been as accurate.
That's absolutely correct. Data accuracy depends on the expertise of the people. Now, I may have a medical degree, but I'm not an expert in talking to a particular Bangladeshi community or a Gujarati community or know where they live and why would they talk to me at all? They'll say, oh, you're a nurse or you've come from the government, you're asking personal questions. Get lost. But someone who belongs to their community, they'll say, oh, you're my neighbor. You want to do this work. Come sit with me. Have a cup of tea. So it's all about personal connections, human connections that matter. And it's humans that matter the most. And only then we can give them technology to ensure accuracy and to see that the work is being done.
et lorsque l'on parle de données, lorsque l'on évoque
When we talk about data, when we talk about health issues, especially when we discuss an epidemic like tuberculosis, thanks to those local workers from the communities, you get right quality data. And also you're sure that you don't have people that go undetected.
Yes. So the challenge in a disease like tuberculosis is there are more than 10 million new cases every year. And hold your breath, 4 million people are going undetected every year. These 4 million people are suffering, they are dying, they are infecting others because each patient can infect 12 others every year. So there is a continuous increase, it's a mushrooming effect. What can we do to break the epidemic? There is to curb the epidemic. There is no vaccine, there's no effective vaccine. We don't have the 2 drops as we have for polio. The only thing we can do is effective case finding, like you've rightly pointed out. So when we hire local health workers, we tell them, we will give you cash incentives, $3 for every patient you detect. Give them a technology application on the same tablet that is used for e-compliance, which has a series of questions. And wherever we've used this e-detection application given to local people, our detection rate has gone up by 20%, productivity up by 20%, costs down by 20%, which is very important because money is very important and the donor's money is a sacred trust. We have to give value for the dollar, and this is where technology is of great importance.
Vous avez fait le choix, puisqu'on est sur une table ronde, vraiment autour de
So this is a round table around a collection of data, and you have decided to use digital footprint. Why did you decide to use something that sophisticated to securize or make data safer?
Started because we don't believe that everyone is totally honest. And when we started our work, we found that our health workers were telling us every patient is getting every dose daily for 6 months. Now, how can there be these kind of results? And we realized that these people are fudging data, our own health workers, in order to get incentives. Because when we give incentives for better performance, that is where we need technology to ensure that the work is actually being done. And we collaborated with Microsoft Research in 2009, and we told them this is the need. We want to monitor every patient health worker interaction. What can we do? We thought of many things. We thought of voice recognition. That didn't work. People told us to facial recognition. Now the challenge with that was that TB patients will not allow a photograph or the face being recorded digitally because of the stigma. The mother will say, oh, my child, she's got TB, she'll never get married. You're taking a picture and putting it on the computer. But a fingerprint, every fingerprint looks alike. No one can say, this is my fingerprint. Shelley's got TB if my fingerprint is there. So that is how we decided to use fingerprints, and we are very happy with the results.
Shelley, vous avez
Shelley, you mentioned Microsoft, and for you, I know that the work that you performed in Microsoft is very important. Can you tell us how important is what to work with an international company to harvest your data? Because you could have been afraid of working with such a big company.
Oh no, I feel that it's all about shared value. So we are not on opposite sides of the fence. We are working towards a common goal, whether we are a corporation or a government or an NGO. And the goal is development. The goal is to serve the people. And having shared the same philosophy with Microsoft Research, we decided, let's go ahead. And we were very successful. We had no difficulties because they did it as a research project, which was part of their requirement. We did it because we needed it to improve our results and our performance and to get accuracy of data.
Toute dernière question.
Last question. I know that your system is interoperable with the National Indian Health System or Registry. Does the Indian government has access to your data? Can they access to the name of the patients potentially? And what use do they make of your data?
So we use data for many reasons. First of all, to improve our own performance. At the click of a button, we can know which health worker has done what on which day, which center has got so many patients on which day. Everything is there in black and white. Now we come to a very important point that you have raised, that of patients' names and patients' privacy. I firmly believe that while we are collecting data, the other important thing is that the patient's privacy must be maintained. And the other side of the coin is we have to give records, we have to give information to our donors, we have to prepare records for the government, for the WHO, for donors, for the auditors and everybody. And even for research purposes. We did a research project with University College London where they picked up all our e-compliance data and they analyzed it. So what we do, we anonymize the data, remove the patient's identification parts out of it, and then share just the actual technical part of it. And even when we collect the fingerprints, the data is encrypted and it goes to the SQL server in the cloud, and decrypted.
Pardon, et quel usage?
What does the government do with the data that you provide them with in terms of epidemiologics, in terms of health safety, etc.?
So the government believes that data in our country, the government believes that data is very important, and our Prime Minister, Mr. Modi, is focused now on TB eradication. He's fast-tracked the TB goals and saying that India will eliminate TB by 2025, not 2030 as the rest of the world. Now, these are very ambitious goals, and this is why our data has become very important to the government. They are using it to see how well we and other NGOs can perform and how we can do things better, faster, cheaper, and deliver results.
Anne-Marie Anchoué, lorsque vous voyez cet exemple...
Anne-Marie Anchoué, when you listen to that example, this example from India, for you in Gabon, is it a source of inspiration before we get into more details of what you do? Well, pretty simply, we do see a very operational system in India. They reach the last kilometer, they see all people, even in remote area, and this makes it possible to provide quality care to people who elsewhere wouldn't have access to that. So congratulations and bravo for what you do. Well, so in Gabon, you also harvest data in a different framework. So generally speaking, how are you organized to feedback data in Gabon? So Gabon, 80% of our territory are forests. And in this context, we are obliged to use e-health in one or the other way. Now, harvesting data, we need to use different tools according to the type of data. We have epidemiological surveillance data, which are collected on a weekly basis, and the people in charge of epidemiological basis feedback that information every week by phone. Now, concretely, you say that we see a number of diseases becoming more and more prevalent. So do they use paper? Do they use text messages? We do not have a specific application. The data are harvested by people in charge in the different departments, and they send back by phone. So we do not have a dedicated app on a smartphone. So it's done by phone on a weekly basis, because it's very important to know whether we have some signs that a pandemic may be starting. Now, The surveillance data are mostly about those diseases with the potential to become an epidemic. We also monitor the number of fatality in mothers. We audit on a very regular basis when we see a couple of mothers, 2 to 3 mothers dying in childbirth. This is also something that we collect very strictly. Then we also collect data more routinely. Those data are collected by the department to the government on a monthly basis. And in this monthly report, we then collect all those data and also provide a quarterly report. There are meetings every month with people in charge, in other words, to analyze those data, validate that, and that we feedback those data through tablets. In the last 18 months, we have started the digitalization of health data. And so tablets were provided to all health bodies, and they help sending the data to the government. So from the regions to the government, but also from the government to the region. So when you talk about collecting routinely data, can you provide concrete examples? Well, we collect the number of pre-birth consultation, the number of child comprised between 1 month and 12 months being vaccinated, the number of malaria cases, the number of malaria cases diagnosed and treated. So it means that every 3 months, when you receive those reports, you can adapt your prevention programs. Do you have a reactivity on a 3-month period? No, not at all. So we collect those data to have statistics on health. But then we have a meeting in between the different region directors, and this is on a monthly basis. So we have different regions, and then we see, well, in this region there have been a number of cases of diarrhea or malaria. And so this first analysis is performed by peers in the different health regions. Now, at the headquarters level, we have a reactivity which is a lot quicker, and we also integrate those statistics in the planning for the coming years. Also, when we design the budget, and those data, of course, are very important in that respect. You say that one of the challenges you face, because there is always avenues for improvement, is the lack of feedback. What do you mean concretely? Well, it is not so much a challenge, but something that we lack. So we request quality data from our healthcare professionals and health workers, and we think that it's also our responsibility to tell them about the quality of their work, first and foremost, to motivate them, and also to bridge the potential gaps. To date, we do not have this complete loop. We do that on an ad hoc basis, and so the regional directors are responsible for providing that feedback to health workers. Now, what we are starting is that at the strategic level, we would like to organize a meeting on a quarterly basis with people in charge in the departments, in the regions, so that we can analyze with them the sort of data they provide to us, and also to provide them with a quality feedback, a positive but also negative feedback. And also we want to listen to them. We want to listen to their needs so that they can tell us, well, we've had that meeting with the other health region director. We think that there is an issue and we would like to communicate our concerns to you. And in the same way, we would like to be able to tell them, well, the data that you collect would need to be more accurate for us to move forward. So we do not have a dialogue rolling, but we'd like to start it. Yeah, that's very important to include all actors from the field to the decision makers. Abdoulaye Banir Diallo, you're from Guinea, but you work in Quebec. You are a specialist in this area of health. Now, from the first testimonials that we listened to, when we talk about collecting health data, we're not faced with an IT problem or a technical problem. First and foremost, it's a human problem. Yeah, well, I fully concur, but this is a joint problem. We need technology and we need the right human resources. We need to make sure that every time we develop a technology or we try to solve a problem, we should make sure that the technical solution do not change the behavior of people in the field. And I think that the example that Shelley mentioned is a very good example, because technology is here as a support to local workers. They use it directly in their own ecosystem. Yeah, we have many examples in Africa of data collection which were failures. You mentioned the problem with the Ebola virus. What went wrong with the Ebola virus data collection? Well, many things, I think, and we're not going to dwell too much into the details of that failure, but the first problem was an emergency. It was an emergency and a number of decisions were made from the outside, not taking into account the social, cultural environment of the communities. And so there were a number of things that were imposed at the grassroots level. And it created fear, and it also prevented us to collect data properly. So either the data was of poor quality or it was not comprehensive enough. So to have quality data, we need to be supported by people in the field. So we do see that, be it in Africa, in India, the theme of data harvesting is a major question. We collect a lot of data. Now, you are a researcher in medical informatics, and you say, or medical IT, and you say that maybe we collect too much and maybe not the right quality. Now, we collect a lot of data and then we don't know what to do with it. Well, it's true, and it's interesting to see that we talk about collecting or harvesting data, but then we should know what we want to do with it. And of course, we need to be able to plan for the future. We need to plan that technologies are bound to happen, to improve and to progress. So when we collect this data, we need to think forward as well. An example, when I provided an example, in Quebec, we collected genomic data. We've been doing that for the last 15 years. And to date, we realize that technology has improved so much that these data are worthless with the new technologies that are available. So the 15 years of data collection, it was money spent with no purpose. Now, if you think about methodology in data collection, if I understood properly, when you collect data, you need to pinpoint something. You need to have a very precise question. Now, it's not so much having a very pinpoint precise question, but we need to understand the general environment and all questions that may arise. So give us a concrete example. Well, for example, we're going to be to continue on data collection on TB, and so we need to make sure that people are compliant with our treatment. But of course, those data need to be analyzed with a number of other metadata. For instance, to do surveillance, to perform forecasts, regional forecasts, and be used in other contexts. So it is collected for compliance purposes, but also it can be used for other purposes. Now, in what you say that we need to think forward. Now, in Canada, I suppose that you're good at collecting data, and you're telling me that what you've been doing in the last 15 years, you get worthless data. So it's complicated to project in 2035 what we will need in 2035. It's a very difficult task. No, not at all. Not at all. We need to make sure that the services and technologies will be on a par. So instead of collecting data that are pointless, we need to be sure that the data that are collected serve today, but potentially tomorrow as well, instead of waiting 10 years before making sure that those data are pointless. Manish Kumar, you come from India, but also you teach in the United States. I suppose that you have the same rationale. You say that we collect a lot of data, but then the real use of data is very low. Do you agree with that?
The points are right. Based on my global experience, we collect a lot of data, and we definitely don't use all of it. So that's true. And one of the reasons for both the problems is the people who decide what data needs to be collected are not always the same who use that data. And I think my colleagues who work with the ministry, they will agree, the frontline workers who are supposed to provide, healthcare services, they collect most of the data that goes up in the chain. And the point where it is used is largely way up, not at the point of care, because they don't have time. So I think the rationalization of what is required to be collected is still there, even though countries are gradually moving in that direction. And the added problem is, in the same country, for the same program, and I'll take TB as an example, you'll see 5 different systems collecting data, feeding into the national system. But how much government uses, how much you use as a community will be very different. Some organizations do it very, very well, but others still have the problem. So I think you asked my colleagues the question about the human and technology part. I think it's very hard to say that this one is the more important problem than the other one. From our work, we take more of a systems perspective where there are different pieces. They all are connected. It's very hard to take community out of the healthcare system. It's very difficult to take the technology out of the healthcare system. But it's always the human which remains in the center when we design anything, whether it's a policy, whether it's a technology, whether type of healthcare services, what data we need. So I think if we remember what data we are collecting and how does that improve the health care of that particular individual, it will simplify a lot of data collection and data quality.
Ce que vous dites là est extrêmement important.
So what you say is very important, especially when we think about decision makers in health policies. So what does it mean? Does it mean that we have to be even more precise, to even better define the health policies at the national level?
So I would say that countries have policies. If you look at the World Health Organization survey, almost every country you'll find some kind of health information system policy. It may not be very well defined by the WHO standard, but they do have something. So it's not a problem of the policy. I think the general problem is the way data is collected. That's what the term that we use is the information architecture, or the information, the way it flows from different points of healthcare services at the district level or at the national level. I think that's not very well defined and coordinated. The governance policies are not very clearly articulated. The data standards are not very clearly defined. So data keeps flowing, but the problem happens is the person who collects all the data then starts having trouble what this data means. Because how you defined age and gender is different from me, because you have different age groups than I have. And when I look at the data, I don't understand. Because I have a 15 to 25 group and you have 15 to 19, 19 to 24. So I think there's a lot of issue there. So policy, yes, in terms of setting up the governance structure, but then making sure that it's followed across different systems, I think that's even a bigger challenge.
Là aussi, vous pointez du doigt un aspect qui est très important.
Well, yeah, you do underline the importance of people harvesting in the field, but also we asked about the demands and the requirements. And what you say is that data changes. There are flows, and data can be corrupted as well. Can you provide concrete example of this flow of data that you just mentioned?
Yeah, so I'll not name any country. I think that's not a good idea, because I think every country has a problem. You take even United States, they will have a lot of problem on data, and I'm not the right person to talk about United States data. So based on my work, so I work on the HIV systems, where we have data coming from 50 plus countries right up to the facility. We also have a work on TB, where the 23 priority countries. And when we look at the data and we try to come up with a national picture, it's very hard. The reason is, in most of the countries, government does not provide services, all the facilities. So you'll see part of it is with the government, part of it is with donor-funded organizations, and they don't always share data, or they don't have a mandate. In some countries which are, I think my colleague from the French Agency for Development mentioned that that political commitment. So the countries which has very strong political commitment, they're making donor-funded projects to share data through the government system and then use it. But in many places that doesn't exist. What it means is then you collect data at multiple places. You report certain data to the ministry based on what ministry is asking for, and it better be good numbers and good quality. Otherwise, you can be in trouble in the country. But then you have to comply with very different standards if you're reporting to WHO or if you're reporting to your donor. So you'll see the mandate that comes also leads, there are very fantastic statistical methods that you can use to make sure your data says what you want it to say. So we have seen countries where, they will extract data from the ministry, they will apply some statistical methods so that, you balance all those age differences, which ministry doesn't want, but the donor wants. Right? So there is no way you can figure it out if you don't apply some kind of adjustment methods to meet the requirement. So yes, data gets very fuzzy, and that's why people there will complain, we cannot use it because this is government data and it's not good quality. But that's not always true. In most of the countries we have seen, they are doing fantastic job. If you look at 10 years back and now, their health information systems are very, very good. So I think the more we use, the more quality of income. That's one argument, and the other one is we need good quality before we use it. So data does get corrupted based on how you aggregate, how you exchange. So it's a problem. But so to address that problem, I think what we have started doing is there are few fundamental things that you can do. It doesn't matter which system it is. One, if you know what indicators you are going to look at, just agree on a common definition. What do you mean by that indicator? What government means, what as a donor we mean, what as an NGO we mean. If we agree on that indicator definition, fantastic, because then we can map your system versus my system. And the second thing we do is, if you call a health clinic A and I call it B, then there will be again a trouble even if we have the same definition. So the second thing we do is we say, let's agree what is your clinic A and what is my clinic B are the same, and you can use the geo coordinates if it's there. So those two fundamental pieces, help. So we have benefited a lot in many countries, and that has shown huge data quality issues on the same indicator collecting from the same government system and a donor system. So I think those are some fundamental pieces that we can do, and they are relevant across any information system that you can choose.
Merci de ce rappel méthodologique.
Thank you so much for this very important methodological feedback. And indeed, it does shed some light as well on what you want data to tell you, whether you're on the government side or on another body side. Dr. Tayak, do you have the same issue that were just mentioned by the other countries?
Okay. Good morning, everyone. I would like to share with everyone Finagel's 3 laws of information. The first one is the information we have is not what we want. The second one is the information we want is not what we need. And the third law, the information we need is that we don't have yet. So we have to prioritize to make sure that the health information is one we need. So in the Philippines, for example, we honor our commitments to our international commitments, so we align any indicators, any health information system that we have to create or establish or maintain, like, for example, the Sustainable Development Goals. And now it's all exciting in the Philippines because we have the universal healthcare law, and we have to make sure that our information systems would address those that will make universal healthcare happen.
Est-ce que vous pouvez nous citer, pareil, des exemples?
Can you give concrete examples in the Philippines of programs that you develop, some successes, some maybe difficulties, so that we can benefit from your methods?
For example, we are very particular with the purpose for which a health information system is created or established. The purpose is important because it determines everything. It determines the system, determines the investments we're going in, it determines the indicators. For example, we have the electronic medical record systems. We have a separate system for the primary care facilities and hospitals. We do not restrict third-party health information systems, but we have the policies that, one, it should benefit the poor. The poor can use it. So if the poor cannot use it, it's a no-no. 2, it should be certified. At the very minimum, it should be interoperable with systems that are created for free. And this is shared for free by government. In the Philippines, we actually balance our applications and tools that we design, those that are in-house in design or that which we will outsource. We decided for electronic medical record systems that this will be in-house so that we can tame the competition from third-party vendors so that they don't create a market price that does not allow health facilities to use electronic medical record systems.
Ce que vous dites est passionnant, puisqu'évidemment...
Well, that's quite passionating. Obviously, in all countries of the world, we're trying to have this health record. We discussed previously the collection of data by health workers. What happens in the Philippines when you discuss about a health record? How is it going with nurses, with healthcare professionals, be that in the hospital or in a community center? Do they accept today to collect data and provide their data to you to fill in those questionnaires and fill in those records?
Okay, for example, for the electronic medical records, we anticipated that providers will not be encoding data, but they will be providing data from the information they get from patients or clients. And so there's a coding staff. So the providers, they collect the data, but the encoding is done by another personnel, the coding staff. So we have to make sure that the education is for both. Otherwise, we will not be getting quality data. And so on a regular basis, we have to do validation. We use standards, coding standards, like for example, the ICD-10, and we have to detect the timeliness and accuracy of the data. But we have bias on the timeliness of data so that we'll be able to understand what's missing from the data that's being transmitted. For the providers, the primary purpose of the electronic medical records is to make sure that they are able to manage patients. But for the central office, the Department of Health, the purpose is to collect data for policy. And so therefore, data remains with them at the point of care to manage their patients, but we extract data, we make sure it's secure, it's stored very well, it's shared, and it is for policy, not for managing the patients.
L'une des choses les plus importantes, on le voit dans...
One of the most important things that we see from this roundtable, when you collect data, we realize that it's important that everybody's on board. So people at the grassroots level need to be motivated to give the right information. How do you motivate those people in the Philippines?
It's more than motivation, Lionel. It's about the culture that they will embrace digital technology or any technology. Technology can only help so much. And so therefore, we make sure that the public who use it, because they are the owners of data, have a better understanding of technology, the purpose for which this data is collected from them, and that they're sharing it with us. And that the providers and other users of data will have the same culture, because we believe that performance drives demands and demands drives performance. If you use the data more, it will drive quality. And if there are more users, and it will produce quality data will increase the users.
On parlait d'encourager ou de motiver, de responsabilité.
Now, we were just saying that we have to empower people who are working in the health environment. Now, Anne-Marie, now you gave iPads to everybody, and especially to health professionals, and you also decided that it would be their own tablet a few years afterwards? Answer, yes, but this is not only an incentive. What we really want to do is to encourage them to use the data they have. This can be a work tool. We know that a tablet can be used in many different frameworks, but we really want them to use this only for professional use when they have to transfer the data that they have collected. This for a period of 3 years. So we have to make sure that they will use appropriately this material. And therefore, after 3 years use, the tablet is their own own tablet so they can keep it for themselves. It's the only way for us to make sure that they will take care of the tablet during 3 years, and therefore there's only one which is given to these health professionals. We thought that this would be a good way of encouraging them to make sure that they take care. So this has really worked. Yes, it has. We were successful. And let's not forget that we don't always have phone systems, that we don't have electricity in some areas. So 3 years after using it, well, they can keep it. And sometimes, well, they won't even think about buying one. Now, what about Philippines? Do the patients have access to the data? Because we speak a lot about collecting, harvesting data. We're not speaking so much of patients. Now, what about the patients? Do they have their own medical record?
They don't have. But they have access to it at any time. So it's not portable, but they can have access. And there are restricted access for others, so we will also use data. We are bounded by the Data Privacy Act, and there are certain data elements that can be shared, cannot be shared. There are data sharing agreements, but the patients, because they own the data, they can have access. But it's not something that's portable.
Abdoulaye Diallo, je me tourne.
Now, Nathalie Diallo, I would like to ask you, when we speak of data, when we speak of patients, it's always the same questions which comes up. That is to say, well, we have data which have been collected, and everybody is really concerned about the fact that what happens to the data. Now, do you believe that the fact that we collect data which is anonymous is a problem which concerns rich countries or southern countries? No, that's a tricky question. A tricky question. I'll try to answer. Okay, well, I believe that we should address this issue because very often things are too complex, especially when it comes to collecting data. Sometimes these systems are too complex, especially once you want the data to be anonymous. And if you use technology, it's easy to make sure that it's anonymous, but you have to be able to find the person who is behind the data. So if we want to make sure that we know what the challenges are, we have to ask ourselves, do we need so complex systems? I'm not so quite sure about that, because we have technological means which can help us in a more comfortable way, which are safe and also are ethical, because this is important. And also keep in mind that the startups that we have are competing one with another so as to provide us with really useful tools. Now, this is almost the end of the roundtable. Now, I would like to ask you, because you've been working in Canada with many research people, do you think that we have serious competitors? Do you think that countries are competing one with another? We've been speaking a lot about China. China is able today to collect thousands and millions of data. So do you think that we're going to have a real competition going on between USA, China, Europe, and Africa? Answer, yes, I think that there is a real competition going on because we have augmented services. That means that this generates new economic values, and there is a competition going on. This is obvious, but let's not forget that when we speak of health and health data, this is to help. This is because we want to be supportive, because we want to support our populations. It's a service which has to be accessible and which has to be opened, and it's more important than this economic war. Yes, there's a real war going on today concerning economic data. And what about the United States? I think that they're collecting a lot of data, but and the United States with a small spout, for instance, or whatever sample you have for medical reasons or medical purposes, you have the whole information which is registered by the United States. They even sell this information. For instance, I can use this information in India or in any country. I was speaking of DNA samples, for instance. Now, how do you feel about this? Because you live close to the United States. What do you think about this? Answer, yes, I think it could be worrying, but it's also reassuring because for some years now we've been trying to make sure that we have the same kind of data harvesting, because we're going to need this data. And it's not only at world level, but also at local level. So we need genetic data, we need health data for many services, and in the long term and a short term, it's better for us to have it at local level. Now, Anish Kumar, now just as a way of conclusion, I would like to know how you feel about this war that we're talking about. You think this is going to be a war between different countries using all the data we have?
Yeah, it's a very interesting question that, everybody, whether it's a government or private companies, they all are fighting over data, and that data belongs to none of them. It belongs to people like us. But we are not part of that whole conversation, and it's also the same in healthcare. And I'll give you one example. So there are countries, for example, one of the issues that has come up recently between India and US is, where do you store the data? So the government of India came with a policy and said, we want to store data locally. Any company that works and collects data from the people need to store it. But that has a huge problem, because if you don't have access to data, you're in one way, you're limiting the innovation based on the data that a lot of companies have done. So that's a trade issue. It's nothing to do with health issue, but it's a policy issue. And my guess is that sooner or later, more countries will go in that direction, because they also realize data has a lot of potential value. Companies can come collect data, and then they will go ahead and use it. So yes, I think data is going to be a problem, and unfortunately, it's the people who will be left behind in that conversation, and the governments and companies will figure it out, and you and I will just go with what it is. And one of the biggest bottlenecks from my experience is, you go to any website, whether it's health, e-commerce, and the moment you click on their privacy policy, I doubt anybody reads it completely. And even if you read it, you will understand it completely. The only thing you do is you say, yes, I agree. And under that, you already gave all the rights, all the legal terms which are there, you lost your data. So that's why we are not part of that game, because we don't understand their privacy policy. They're so complicated. And I've done some research, and we realized one of the reasons why people don't pay attention to it, they need something, and they assume it will be good. So yes, data is going to be a problem, and we will be the one who will suffer the most.
Belle question pour clore cette table ronde.
Very last question. So as to put an end to this roundtable, what about tuberculosis? It's not only in India that we have this problem, or in other countries. So this is a question for everybody. It's important for us to know what data means, and thank you for this participation, because I think that you've been giving us a lot of insight concerning your countries, and maybe we have many comments or many questions from our audience here and elsewhere. So if you're listening to us, if you're on your internet platform, or you can use the small link that you have, which is a comment for comments. So you can congratulate us, you can tell us how you feel about this conference, or if in this room. So I think that we have a few questions here from Amma in Morocco, and she says, now, coming back to what Mr. Kumar has said, how can we make sure that there will be an optimal use of the data which has been collected, and help people to understand what is at stake? That is to say, how can we be more precise concerning this methodology? Could you answer, Mr. Kumar?
Very good question. One of the challenge in data use is, when you say data use, I think, even in this room, we will all have different interpretation of what we mean by that. So optimizing data use, I think the way some of the work that I have been involved is, you look at the level where you're talking. So if you're talking at the frontline health worker level, your definition of optimal data use will be different than the supervisor of the frontline health worker, the manager of the facility, and like my colleague said, in the ministry, in the policy making, they will be different. So just understanding, and I think my colleague from Philippines made a very good point, and it's very rarely asked. You go and look at health information system, and in terms of data use, we don't ask what was the purpose for which this system was designed. We start asking that system too many questions, which is never meant to be answered. So to optimize the data use, first thing you need to ask is, what is the question or healthcare question that healthcare provider is trying to answer? And then you see whether you have that data or not. And that also helps decide what additional data you should get. I'm not saying collect, because you may have other surveys and other sources that you can use rather than going for additional data collection. So define the question that you would like to ask or to address, and then you find out the data that you need to answer. So that's one way of optimizing data use at various levels. And the hardest part is you'll have tough time defining that question. So if you can figure out the question, which we haven't figured out yet, I'm sure we can optimize data use. But please start with asking the question, what decision we want to make and what we need, rather than looking at what we have and what can we do out of that. That's another way of looking at it.
Des questions dans la salle en général.
Questions in our room here. So, first question. Good morning. I'm Shukumar from Bamako. I'm in charge of the Bamako internet system. My question is for Mr. Kuma. I'm very happy to see that you have this systemic vision of this information system, but the question that I have in mind concerns more local issues and issues that we have in Africa. For instance, I wonder if your systemic vision is now being shared by other organizations. So what happens, for instance, locally? What do we need locally? I think that this is what we have to ask. What kind of information system we need, because we have to have a systemic vision, because one patient is going to go from one system to another. But I think that we need a specific tool, and we have to say to our government, this is the tool we need. This is the tool we need for a systemic vision. And when we have this tool, then we're not speaking of design anymore. That means that they're not going to lose time in designing systems, but they're going to use the tool, and this tool is the one that we can design. Very often people, even at government level, they don't know what we need. We're not going to have a miracle with some tools. We have to design the tool ourselves because we have the information, and the systemic vision is no longer useful. So how do you feel about this? What kind of assessment do you have so as to change things and make sure that we can be a consultant for the governments and explain to them what we really need, and this in the light of our health policies? Now, Annie Kushma, but also other people can answer the question.
I'll say one thing first, that system of thinking vision is not mine. It comes from WHO and others. And I think the important point there is, when you say system, you look at organization as a whole. And if you look at Ministry of Health, I don't think Ministry of Health will exist if there was no community or facilities there at that level. So that's part of the whole vision. I think the biggest challenge that we have is when we design our system, the way we look at information that flows from facility up to the policymakers, I think the value gets lost that most of the times the data is collected from the patients. You go in any healthcare setting and you'll see a patient comes to a facility, you collect the data. But then the data gets aggregated and gets reported everywhere. But that individual data is lost there. The frontline workers spend most of the time aggregating and send it. So in the system design, you'll see that part of the design just gets neglected. So it's a problem in the architecture. I think the way I have been looking at it is you collect the data, and the first thing your design or system should do is let that frontline worker use that data to deliver the care that they are supposed to before it gets aggregated. And I think it's a design problem. It's a technology design problem. It's nothing to do with labor. And the three key things that I have found is, one, stakeholder involvement at different levels is not very thorough. And architecture is a problem, and then you don't follow up. So it's not about systems problem, but I think the way we look at our community and the role we assume for them is very different than what you just shared.
D'autres questions d'internautes tant que
Now, another question of people who are on internet. Antoine says, well, thank you. This is a very thrilling, exciting conference. And this is a question now for Myriam Beni-Diallo. So do we have specific projects concerning e-health like Google? Because they're so powerful from a technological point of view. Could this be interesting for us to use what they know and what they have? Yes, I think it could be a threat, too, as you said. said, it could be a threat, but I know that Google really wants to develop some e-health projects or programs. I think that there are thousands of stakeholders who are now involved trying to design these systems. No, we shouldn't be too worried. And as our friend from India has said, instead of being afraid, what we have to do with these service providers is try to find solutions for local populations in partnership. It has to be a win-win agreement, and this means that we have to abide by the laws we have in our own countries. Are there questions in the room or not? Yes, you have a question. Thank you. I'm Professor Idrago. I'm in charge of the health information system for Burkina Faso, and I have a question which could be for Mr. Diallo and Mr. Kumar, especially concerning the interoperability of systems. How can they work one with another from one country to another? I'll give you an example for Burkina Faso. We have had different applications which have been designed, and we have 80 different applications today which have been implemented in our country. Now, how do you feel about this? Do you think that the different countries concerned and the different governments could avoid having only a vertical development and could have a kind of transverse development? That means that we can work together, that we can have systems which can work one with another, because these are tools and people don't really know what the difference is between a tool and what the output is when you have a decision-making process. So many countries have this difficulty, that is to say interoperability, that is to say how can we take into account all these applications and have all these systems working one with another and avoiding having only development at very specific levels, which then will not be used in other countries. For what would the recommendations would be on the ground of your own experience? That is to say, how can we solve this problem? So Abdoulaye Banire Diallo, could you answer, and then our friend from Philippines and our friend Mr. Kumar. I think that this is really a major challenge because we have too many tools. I agree. This is because we don't have enough local expertise, and I think that when we have research going on, we haven't been developing what we call local or in-house expertise, and this would help us because that would mean that we could develop systems which would be interoperable, that could work together. And I think that it is our government, our different governments should face this problem because we have too many tools, I agree. But if we have specific tenders, if we have norms, if we have students who are trained in our companies so as to be able to work according to these norms, then at a 5 years period, for instance, we will have a minimum of interoperability. Now, Manish Kumar, could you say something?
In that region, we have done a lot of work, and especially there is a project called Digital Square, and post-Ebola situation, I think they've done work on interoperability. And you're right, there are multiple, and by tools, I'm assuming that you are referring to digital tools, because I think there are multiple of them implemented. So yes, it's a big problem, and some of the things I mentioned earlier, the fundamental things don't exist in those countries, and because there is a crisis, so you come up with whatever you can do to solve a problem for the time being, but by the time you move out, you realize you created another problem. So we in part of our global work, we developed our assessment, and I'm saying assessment tool is not a digital tool, to understand what is the interoperability capacity of those countries. So far we have done in 5 countries. Uganda was one of them, mostly in East Africa. That will give you a very good idea where exactly you have a problem. Some of the things you're talking about is more about standards. None of these systems really comply to any global standard that you can use and exchange data. They all have their own vision. So that's some of the work that we have been doing and pushing, that these tools needs to comply with some global standards so that when I'm ready, I will be able to exchange data with my limited human resource in that country. So there's resource. If you want to know more, I can talk with you more later.
Eric Taillac rapidement, et puis Madame Anchoué.
Eric Taillac and Madame Anchoué.
Organization or maybe the observatory can have an inventory of these applications so that there are case studies for each application so that countries who wish to use these applications can learn from existing applications. It always begins with the first question, why do you need it? And if you're not clear about it, don't start anything that will be regretful for all those who will implement it now and in the future.
Madame Manchoué.
Mrs. Manchoué? Yes, I would like to answer to the question, but I think that very important comments have been made here by my colleagues concerning interoperability. I think that interoperability is not something which is going to be decided upon by our own national entities. In Gabon, for instance, decisions concerning interoperability with these applications have been taken. And what we're doing today in Gabon is trying to find a specific framework to make sure that all our stakeholders and players can use these systems. So we have to do this at local level and not only trust the most global systems. And what about confidentiality? Confidentiality is also paramount because we should not forget terrorism and hackers. And this is something we're going to talk about. Yes, thank you. Thank you for all these comments and for this wonderful roundtable. And I think that they all deserve a round of applause.